to excessive calcium buildup. This makes your heart work harder to pump blood through your body and limits your normal daily activities. Before the procedure begins, you will be given anesthesia or sedation to make you comfortable. The entire procedure typically lasts between 1 to 2 hours. The arteries in your body are like a system of roads that branch out from the heart. There are different routes that your doctor can use to implant the Evolute heart valve, and all come with their own individual risks. So speak with your doctor about what route is best for you. These routes include an artery in your leg, an artery in your neck, a space between your ribs. In a typical Evolute procedure, the doctor makes a small cut at one of these access points and guides a thin, flexible tube with the heart valve into your artery and up to your diseased valve. When the heart valve reaches the diseased valve, the features of the Medtronic Evolute heart valve allow your doctor to reposition the heart valve to assist in accurate placement. Once in place, the self-expanding frame of the Medtronic heart valve enables your doctor to deploy it in a controlled and accurate manner. After expanding, the new heart valve takes over the old valve's function to help blood flow efficiently out of the heart. Once the valve is accurately placed, the thin flexible tube will be removed, the cut will be closed, and the procedure will be complete.
Methods. In this trial, the guideline was a risk score of at least 4.0%. The upper limit applied by the Case Review Committee was 8.0%, but this value was not pre-specified. Patients with an STS risk score of less than 4.0% could also be enrolled if there were coexisting conditions that were not represented in the risk model. Patients assigned to TAVR underwent either transfemoral or transthoracic placement of the valve. Transthoracic placement, it used the same valve placed through either the transapical or transaortic access route.
The clinical question for the SURTAVI trial was to find out how people with symptomatic spheric stenosis did versus surgery and people that were intermediate risk for surgery, since we had already answered the question for high risk and extreme risk. We randomized over 1,742 patients. The people that we enrolled in the SURTAVI trial were intermediate risk, and the definition for intermediate risk was that the heart team felt that their surgical operative mortality would be between 3 and 15%, based on both their STS predicted risk of mortality and their clinical status, which include frailty, disability, and comorbidities. When we look at the demographics of the SURTAVI group, these were an elderly group. They're almost 80 years old. The STS for TAVR was 4.4 and 4.5 for surgery. The primary endpoint was all-cause mortality or disabling stroke at 2 years. And what we found is that when we reached 2 years, the all-cause mortality or disabling stroke for TAVR was, I believe, 12.4, and for surgery was 14. In addition, at 30 days, there was statistically less stroke, statistically less transfusion, statistically less kidney injury, statistically less cardiogenic shock, and statistically less atrial fibrillation in the TAVR group. There's still more paravalvular leak for TAVR than there is for surgery. There was 5% versus 1%. But remember, 84% of this trial was done with the first generation core valve. Only 16% were done with the new Evolute R, which has a lower paravalvular leak rate. Pacemakers were higher than we expected in this trial, but again, only 16% were Evolute R. We know from our data from Europe and our data from the US that the pacemaker rate in Evolute R has been lower than it is in the core valve classic. We'd expect it to be about 13%. So these people did well at 2 years, and they did really well at 1 month with faster recovery. This is all really good news for those interested in the TAVR field.
Pros. Several benefits with regard to secondary endpoints were associated with TAVR, including lower risks of bleeding events, acute kidney injury, and new-onset atrial fibrillation, as well as more rapid early recovery that resulted in shorter durations of stay in the ICU and hospital. Cons. There was no significant difference in the primary endpoint of death, severe perivalvular aortic regurgitation, and other rare but potentially catastrophic adverse events.
The aortic valve is one of the heart valves, and literally there's 4 valves in the heart. The last valve before blood leaves the heart and goes to the rest of the body is called the aortic valve. And all a valve is a conduit that blood goes one direction, and then when the heart relaxes, stops the blood flow and prevents it from going backwards. When you develop aortic stenosis, as that valve opens, every time it opens, it gets stiffer and stiffer, and it develops calcium around the ring. It's like a garden hose. You open up a garden hose wide open, there's a lot of blood flow, and you kink the garden hose, and the flow is still normal until you get to a certain point, and then the flow rapidly drops. And that's what happens with aortic stenosis. So people with aortic stenosis, once it becomes severe, get tired walking just a few steps, a block. They oftentimes get chest pains. They oftentimes can pass out or get dizzy with exertion. Now, the key is that once you develop symptoms, we've got to do something about this, because 50% of those people will be dead in 2 years without an intervention. Traditionally, for the last 30 years, the only way to solve that is open heart surgery. So open the chest, stop the heart, put you on bypass. The challenge comes when people are high risk for that. And so what's evolved over the last 15 years is this procedure called transcatheter aortic valve replacement. And it's really amazing. We're able to, through a small incision in either the leg or in the artery under the collarbone, insert a tube that then allows us to deliver a new heart valve that we actually deploy inside the old heart valve without stopping the heart, without putting the person on bypass, without opening their chest. And it has a very, very, very good acute result. The risk of dying, of having a stroke, is dramatically lower than open heart surgery. And 90% of our patients now who have this go home on the second day after the procedure. One of the challenges we have in treating patients with aortic stenosis is, as people get older and get a little bit weaker, physicians tend to write them off and say, well, they're too sick, they can't undergo surgery. This new technology comes along, and then all of a sudden, maybe you can treat people who are a little bit sicker and a little bit older, and it turns out that oftentimes when you treat them, you find out that they really weren't as old and sick as you thought they were, because you took away the thing that was making them old and sick. When I see somebody like that, that really strikes me as this is somebody that we can help. It has been a very amazing experience. We started in February of 2014. We've had a dramatic increase in volume and referrals because our outcomes have been really so good. And it's all due to our team. We have the best team doing this in the country as far as I'm concerned. They are dedicated staff, nurses, radiation techs, perfusionists, physicians, and we have a team of about 12 to 15 people that are involved in this procedure, all the way from working the patients up to doing the procedure to taking care of them afterwards. And we've had really, really excellent outcomes, and we're very proud of it.
Conclusion. In a comparison between TAVR and surgical replacement in patients with symptomatic, severe aortic stenosis at intermediate risk for surgery, TAVR was a statistically non-inferior alternative to surgery with respect to death from any cause or disabling stroke at 24 months. However, each procedure had a different pattern of adverse events.